Hello. It's a matter of great pleasure and privilege that I've been asked to present this talk on EBUS past, present, and future. So in my presentation, I will be talking about introduction to endobronchial ultrasound, endobronchial ultrasound equipment, the EBUS-RP, the radial probe, and the convex probe, indications for endobronchial ultrasound, evaluating the invasion of bronchial wall, diagnostic value of EBUS-guided TBNA in mediastinal and hilar lymph nodes, role of EBUS-guided TBNA in staging of lung cancer, for which this instrument first came to the market, EBUS-guided transbronchial lung biopsy in peripheral lesions. And I'll summarize my slide in another 13 to 14 minutes. I'll summarize. So I must tell you here, EBUS as an equipment came into the bay just to see and go beyond the airway wall and take the biopsies, whether it is a lymph node or a mass lesion, sometimes a thyroid lesion, whatever is beyond the airways. There have also been occasions where we have been able to pick up pulmonary embolism, pulmonary arteries. People thought that this could be used as one of the diagnostic procedures. Actually, we had one of the patients who had a right upper mass lesion with an embolus in the pulmonary artery. We picked up both in one go. So the intention, the purpose for it first came into the market is for looking beyond the airways to take the biopsies. Now it has gone further and further. Now we reached a stage where we're able to take a transbronchoscopic lung biopsy, EBUS-guided. The transbronchial lung biopsy was considered to be a blind procedure when you do not use this screening. Even if you use the screening, it becomes a blind procedure. Now with EBUS-guided, we are able to go to the peripheral lesion and take the biopsies from there. So just to have a look at the endobronchial ultrasound, it depends on the capacity of the tissues with different impedance according to radiations and transmitting in the blood vessels. You have a Doppler built into the endobronchial ultrasound system itself, so that you can look at the vessels when you are putting the needle inside. You can look at the vessels and take the biopsies from there, and also taking care not to injure the vessels. And in a real-time monitoring of the needle, the ultrasound the needle can be seen through that, and it's a real-time monitoring. It's not a blind procedure. So you see the needle, you're in the lymph node and take the biopsies. But just to show you how it looks like, there is a vessel there. You can move it up and down. So then ultrasound indications of defining the infiltration of the airway. Now you can define whether the airway is involved or not. It is much better than the CT scan to tell you whether it is the airway is infiltrated or not, which helps us. Sometimes the narrowband imaging also can help you in telling us the vascularity, but in EBUS, we are taking the tissue and looking at the tissue and getting a diagnosis. We use the mediastinal structures or lesions adjusted to the airway, getting the transbronchial needle aspiration, and getting the transbronchial lung biopsy in peripheral lesions. So the bronchial wall endoscopy, if you look into it, has 5 to 7 infographic layers, and various layers can be identified. But with experience, you realize and you start identifying what actually is there, just proximal and just distal to it, and you get an idea of that and start taking the biopsies from there. This is one of the beautiful slides to tell you how this echo-endoscopy looks and how you can identify the 5 to 7 graphic layers. The advantage of that previous slide is that if you use this, you can show the in-depth invasion of an early stage of cancer in carcinomatosis. Addition of EBUS in evaluation of airway defines the best patient group whom benefits from treatment. If you have a lesion in the right left upper lobe, you want to know whether there is a lesion apart from the carcinoma in situ. You want to know if the airway is involved or not. Is the best way of doing it. Put the endobronchial ultrasound in, put your probe in, and then see whether the airway is involved or not. You can take the biopsies from there and get an idea of the airway involvement and plan your treatment. EBUS airway compression and infiltration. As I told you, EBUS is highly accurate diagnostic tool and superior to chest CT, evaluating the question of airway involvement by central intrathoracic geometry. Compare the EBUS and CT. The sensitivity of the EBUS is about 89% compared to the CT. Many times we'll be missing it. Many times surgeons would tell you there's a tough case, the airway was involved very badly. The specificity of the EBUS is about 100%, whereas in CT is about 80%. The accuracy rate is 0.94, whereas in CT is about 51%. Without doubt, EBUS is an important tool. This is again to tell you if it's airway compression or infiltration, you can identify. This is the CT scan, which tells you whether it's involved the airway lumen is quite well. But if you look at the EBUS, you can see very clearly that the airway is involved. So in a study presented by Hurt et al. In 2,446 children's bronchoscopy patients, EBUS was used in 1,174. EBUS guided and changed the treatment in 43% of the patients. It's a fairly good number, statistically significant. It tells us that EBUS as a tool can be used in situations like mechanical debridement, stent applications, ear lasers, organ plasma, coagulation, brachytherapies, foreign bodies. So in all these places it has guidance. So EBUS-guided TBNA, mediastinal and hilar lymph and in staging lung cancer is being used quite extensively in our country, especially the subcranial node, which is the darling of the pulmonologist, the paratracheal node, the right and the left paratracheal node, the upper paratracheal and right paratracheal nodes, and also the hilar nodes, which can be sampled and sent for bacteriology path, which means bacteriological path. By that I mean the AB smear, AB cultures, and the cultures of Gram-Stein cultures and the TB cultures. You can take a sample for a gene expert, check for the AB culture, and also rarely we have picked up Pseudomonas suramelli from the aspirates of these lymph nodes. We have picked up viral lymph nodes for staging malignancy. Also, you can send and get the stage. And if you're lucky, you can also take a good core material. If you get, you can use the sample also for this EGFR staining and also for this staining. If it's a lymphoma, sometimes it's difficult to pick up a lymphoma, but if you have a good pathologist and you have a FISH technology, the sample, if it's a core sample, even the ICH and the FISH technology, the diagnosis of the lymphoma also can be made on these EBUS samples. So in a conventional and EBUS, compare and see 50 EBUS guided and 50 conventional. If you see 40 diagnostic, 36 are diagnostic, 80% and 72%, which means in a good hands, in a good bronchoscopies, conventional TBNA also can be used, but no doubt EBUS-TBNA is superior to conventional TBNA. Similarly, for a paratracheal node, if we take out of 100, in 50 EBUS guided, 50 conventional tried, in EBUS guided, 42%, 42 could diagnose, that is about 74% diagnostic value, whereas in out of the 50, only 20 in a paratracheal node, the conventional TBNA is a bit difficult compared to the EBUS-guided TBNA. So it's better to do that. If you have a lone paratracheal node, the choice should be an EBUS-guided TBNA and not paratracheal. So the 55 patients, the EBUS-RP compared with CT-TBNA scope, 55 patients randomized 30 EBUS-TBNAs and 25 EBUS-RPs. The diagnostic accuracy of the convex probe was 97%, as against the radial probe of 76%. It was statistically significantly different. The mean number of penetrations was 1.24 in the EBUS-CP group and 1.36 in the EBUS-RP group, which means the superiority of the EBUS-CP is very, very clearly seen in this from this slide. And similarly, if you compare the EBUS-guided TBNA of CCP, if you compare and see with the RP and CP, it touches about 80 to 90% that we are able to get a positive. And in our own series, malignancies, the early phase, we had difficulty in picking up lymphomas. If we thought it was a lymphoma, we never used to do the EBUS-guided TBNA. We should send these patients for a surgical mediastinal node biopsies. But nowadays, with the technology improved, we have a FISH technology. We're able to diagnose lymphomas and also type the lymphomas also in these patients. Comparison of EBUS-TBNA, CT and PET in staging of lung cancer. If you look, EBUS-TBNA, if you compare with PET and CT, EBUS-TBNA is head and shoulders above the CT and PET together. It's 92.3 sensitive, which means even if the PET is negative, 20% of patients where the PET can be negative, we can pick up with the EBUS-TBNA. So EBUS-TBNA is more sensitive. Specificity wise, 100% specific for mediastinal. or with EBUS-TBNA. Sometimes with paratracheal node, subcutaneous node, EBUS also can give a good node, but EBUS and EBUS together, if you can use the same scope for both. There is a paper from Enema, you can use the EBUS-TBNA itself. You can put the EBUS-TBNA in the esophagus and take biopsy. Then the lead goes up quite phenomenally. So less than 10 millimeter node in CT PET versus EBUS-TBNA, compare and see the EBUS-TBNA sensitivity is about 89%, specificity is about 100%, the negativity value is about 98%. Pathological improvements in CT and mediastinal invasion in PT, all NSCLC patients. So what I said, in preoperative staging, nobody should go for a surgery without a EBUS-TBNA. EBUS-TBNA after neoadjuvant chemotherapy, many times we come across patients who have, after the chemotherapy, just want to see whether the lymph nodes are still positive or not. If you look and see the sensitivity is about 70%, specificity is 100%. I also had situations where after the treatment and chemotherapy, we have done the EBUS-TBNA and found out sarcoidosis and tuberculosis patients. So specificities of EBUS-TBNA is pretty high. The role of EBUS-guided TBNA, if you look at the various studies, tells you that the superiority of EBUS-TBNA is very clearly shown in all the studies, and surgical staging was not needed at all. In fact, there was one of the papers of Little et al. Right where it was proved that it was superior to mediastinal, and in mediastinal, the lymph node was not seen in about 60% of the patients, which means EBUS-TBNA for sure will be in the lymph node. The only time when you can be negative is if your node has entered the site where the malignancy was not there. That's only a case where I get a negative report. Otherwise, most of the time you are successful. My pathologist tells me if it is malignancy, it's the least of the issue. They can diagnose blood is the least of the issue. Many times there is a blood, there is always a possibility that you might get a negative report. But in malignancy, there is no such problem arises. The first experience in EBUS-guided TBNA in 35% and out of the 57 people, 97% or 97% is adequate material on your testing, 35% diagnostic, sarcoidosis. It is 84.85% of the time will be positive. No need for further invasive staging methods. But one thing I would like to mention here, that in case you have tuberculosis, sometimes you have difficulty in getting, you might get as a ill-defined granuloma or small necrosis, some difficulties you might have. So that's the only time when you can have some difficulty. If malignancy is 100%. If it's lymphoma, you will have some difficulty. If it's sarcoidosis, you can combine it with the bronchial biopsy and increase your yield to 100%. This is just to show you a case. There are another case wherein we have done a endobronchial ultrasound and picked up a diagnosis. And you can see the tissue that's available for the diagnosis. And in peripheral lesions, if you have a lesion that's quite peripheral, where you have find them, that you might induce a pneumothorax by doing a CT-guided biopsy, you can use an EBUS and then increase your yield. You have a yield of about 60 to 70% is the yield, 30% may not get the diagnosis, but still in 70% you are quite successful in peripheral lesions as well. EBUS and fluoroscopy guided transbronchial lung biopsies, which is less than 3 centimeters, EBUS percentage is, if you look, fluoroscopy guided is relatively less, whereas in EBUS it is much better with regards to EBUS if you see. And if you combine this EBUS with the fluoroscopy, definitely you get a better yield. EBUS guided brushing and BBB also again is one of the important tools by which you can make a diagnosis. And again, it's just to tell you, we have a virtual bronchoscopic image, and we have a lesion like this where you can use the EBUS to take the biopsies from there. In multimodality approach, if you take the EBUS is 69%, electromagnetic navigation is less than, it's about 59%, and combine both, 88% positivity you can get when you combine this EMN with EBUS, EMN and EBUS. And in summary, I'd like to tell you that it is a new and attractive method. It's used in diagnosis, staging, and interventional treatment. is a useful method in evaluating the parabronchial area. It has an important effect on decisions about treatment. It's difficult not to meet the learning time. If you are a good bronchoscopist, I keep telling, and if you have been usually doing a tank bronchoscopy